Hi, my name is Dr. Robert Dunn, and welcome to another episode of Clinilabs Fireside Chats. And today we have an important and timely topic to discuss: treatment-resistant depression, also known as TRD. Depression affects millions worldwide, but what happens when traditional treatments fail? That's where TRD comes into play, a condition that challenges both patients and healthcare providers. Joining me in today's discussion is Dr. James Murrough. He's the Vice Chair for Clinical Research for the Department of Psychiatry and Director of the Depression and Anxiety Center for Discovery and Treatment at the Icahn School of Medicine at Mount Sinai. Welcome, Dr. Murrough.
Thank you.
Maybe we could start with just what are the symptoms of depression?
Yeah. And this can sometimes be challenging because, we use the word depression to mean many different things. In a clinical context, sometimes you'll see the term clinical depression from a sort of mental health diagnosis perspective. We're usually talking about a major depressive disorder, MDD. Sometimes we use the term unipolar depression. So there's also sort of all these. But in a clinical context, it all kind of means the same thing. And non-surprisingly, it's characterized by depressed mood, which obviously is inherently sort of a subjective thing. But the idea is it's meant to capture feelings of down, sadness, hopelessness. And the key is that which are all natural emotions, right? Mm-hmm. But there's something not adaptive, not normal about it that would bring it to clinical attention. And you can think of it in terms of sort of both magnitude and duration. So we generally, the flagship sort of symptom or syndrome we see is down, depressed mood. That's most of the day, more days than not, for at least a couple of weeks. And then we say, all right, this might be depression. And then we go through and there are other associated symptoms like disturbed sleep, fatigue, which is sort of the feeling of not having physical energy. Sometimes there's change in appetite, but really, if they don't have the depressed mood, then they probably don't have depression, with a few exceptions, like particularly in men, actually it can be more irritability. And that would sort of count as the negative mood state. But it's, that's the essence of it.
What's the epidemiology of depression? How common is it?
I mean, unfortunately, it's very common. One of the interesting things, if you look at studies that are conducted in different countries, there's been studies sort of looking at high and low income countries, different cultures. And depending on what study you look at, we think worldwide at any given point in time, probably about 5% of the world's population would currently be depressed, meet criteria for depression. So that's a tremendously large number. If you ask a slightly different question, like what percentage of people, let's say in the United States, at some point in their life would have clinical depression, the number is getting closer to 10%, or some studies suggest it's even higher than that. In people that are surveyed that are in general medical clinics, that have chronic medical conditions, the numbers can be over, getting close to or even exceed 20%. So
wow,
it's very common, and that's part of the reason that it continues to be ranked, if you can believe it, as the across all diseases, the number one cause of disability worldwide, according to the World Health Organization, is depression.
Mm-hmm. What about the heritability of depression, the genetics that have been discovered?
Yeah, in some ways, depression is sort of a classic psychiatric illness where there's been both a genetic component established as well as an important sort of environmental cause. There are some illnesses we have in psychiatry that have a pretty strong heritability. You can think of it as sort of like a proportion, like what proportion of an individual's risk, all the way up to like 100% or as low as 0, can be accounted for with genetics. And there are different ways to do that with family and heritability studies. Illnesses like schizophrenia, autism, interestingly, bipolar disorder, which can present as depression, but usually when we say depression, we mean MDD, and bipolar is something a bit different that we can talk more about. Those are quite heritable, upwards of even higher than 60%, even 80% heritable. Depression, not so much. I'm not sure the exact numbers these days, but it's less than half. So the preponderance of risk can't be ascribed to a specific genetic cause. It doesn't necessarily run in families, although there's clearly a genetic component. So it's sort of a classic nature-nurture interaction. We know that individuals that suffer either trauma during development or just in aggregate have high levels of stress in their life or suffer other major stressors like the loss of a loved one, those all increase risk of depression. So there's a big environmental stress component that presumably interacts with some sort of genetic predisposition.
Now, since the STAR-D trial came out, treatment-resistant depression has been increasingly on the horizon and a target for indications in pharmaceutical development. Maybe you could speak a little bit about treatment-resistant depression.
Really, there's not a completely agreed upon definition, but I'll give you so conceptually, it's somebody has depression. And again, we usually mean unipolar, we mean MDD, but the term can be used in the context of like a bipolar disorder, bipolar depression. But assuming we're talking about MDD, major depressive disorder, it really means that the person has been tried on, at least one or two or more sort of, approved first-line medicines. Think of the SSRIs, right? The serotonin reuptake inhibitors, fluoxetine and the descendants, and some of the other medicines we have. And maybe has tried evidence-based psychotherapy like cognitive behavioral therapy, CBT, and they just can't. They're still depressed, right? That's conceptually what we mean. Someone's still depressed despite a sequence of treatments. I think the most common definition is really just not responding to at least two. Often we're talking about medicines, although psychotherapy has been shown to be, in some studies, equally effective first-line treatment as a serotonin medicine, for example. But typically, particularly if we're talking about, thinking about it as a regulatory, like what is the FDA definition, they're usually concerned more with medicines. And so someone really hasn't responded to at least two medicines.
Mm-hmm.
You mentioned STAR-D. That's in part based on, if you look at the STAR-D data, that took sort of all comers and started them, as you know, on a first-line oral serotonergic medication. It happened to be citalopram. Could have been anything, presumably, right? Escitalopram, sertraline. Mm-hmm. And if they didn't respond, they then went to the next step, and some of the patients had a medicine added or switch. But they found that if someone didn't respond to either the first step or the second, the chance of them responding dropped significantly and kind of stayed low. That was sort of the one of the take-home lessons. It wasn't particularly encouraging for the field. It really suggested, geez, actually maybe the medicines we have don't actually work as well as we thought. That was one, and if you don't do well to a first treatment trial and then you don't do well to a second one, your chances of responding to a third are significantly reduced. I can't remember, but the response rates drop, or the remission rate, which is sort of you're totally out of your depression, which is the goal, drops off by the time you get to the third step. So that's part of the rationale. Once you're in that category, two or more failures, what else can we do? And importantly, are there other medicines or forms of treatment that we can reach for that maybe do they act differently in the brain, right? Do they target different systems? So that's been part of the research focus of trying to understand, if I give you one medicine, I give you a second medicine, I give you a third, but all the medicines kind of work in the brain the same. Should I be surprised you're still not responding? It's still more of a theoretical, but that's the idea.
What are some of the existing treatments for depression and for TRD in particular?
Yeah, so I mean, you've got your what I would call first-line antidepressant medicines that are the serotonin reuptake inhibitors, the SSRIs, like fluoxetine and some of the others I mentioned. Escitalopram is very common. I think there's 7 SSRIs. And then there's another category that is also used commonly either as first line or maybe that second step if the SSRI doesn't work. These would be called the serotonin norepinephrine reuptake inhibitors, or SNRIs. I think venlafaxine was, I think, the first one, if I'm not mistaken. Duloxetine came on the market, and there's been one or two others. There's a desvenlafaxine, which is a derivative of venlafaxine. So they're kind of in our toolbox. And then there's some others. Bupropion's been around a long time. It's not an SSRI, but it does seem to increase norepinephrine and maybe dopamine signaling. That's commonly used. And as I mentioned, psychotherapy, if I'm seeing a patient and they haven't been offered or haven't had a good course of psychotherapy, again, studies suggest that could be equally effective. And then, of course, we can combine these things. I guess I'll mention one other. We talked about those medicines, psychotherapy, and then a third category, which you might call neuromodulation. I mean, classically ECT, right? Electroconvulsive therapy was in that. That was very much in the TRD space. But then other technologies like transcranial magnetic stimulation, which could be used, much earlier in the course, TMS, right? RTMS, much earlier in the course of illness. There are very few side effects. And there's sort of more versions and iterations of TMS. So you can sort of think in three buckets: medicines, psychotherapy, which is talk therapy, cognitive and behavioral therapy, and neuromodulations like TMS. Those are kind of our options. Obviously, other things, lifestyle, right? Eat right, get exercise. We know this. Get good sleep. This is sort of what the doctors are talking to patients about also early on. But presumably for some people that's not enough. And by the time you're trying to figure out what's the second, third, fourth medication, standard things like lifestyle adjustments, either they haven't been effective or they're hard to do, right? But often we're combining things. So if psychotherapy didn't work, we'll add a medicine. If a medicine isn't working on its own, but maybe the person is feeling a bit better, we would try to enroll them in a course of psychotherapy. So we're trying to combine the different modalities or different medicines as you kind of move into the TRD space. You're often talking about combinations of medicines rather than just one.
Maybe we could delve a little bit into new treatments for treatment-resistant depression. And if you'd like to introduce your own research in the area, that would be very welcome.
Yeah, I mean, I'll say, I think in the last 5+ years, I mean, we have seen some new treatments coming online, which is very exciting, and some new things kind of on the horizon. A form of ketamine was approved by the FDA for treatment-resistant depression, I think in 2019. That was exciting for a number of reasons, including it didn't seem to directly affect serotonin. It sort of seemed to fundamentally work differently. It affected glutamate signaling, at least in the first sort of proximal effect in brain. And there's been other things around the same time. Again, a totally non-serotonin-based treatment became the first approved medicine approved for postpartum depression. That was brexanolone, which is sort of a derivative of a steroid, a neuroactive steroid. It also affected GABA. So GABA is the primary inhibitory neurotransmitter in the brain. Glutamate's the primary excitatory. So, and then you can sort of think that the business of creating mental states, thinking, feeling is happening in brain through patterns of activity that are in part come about through interactions between GABA and glutamate. And then the monoamines like serotonin, they're sort of tuning these things or tweaking them. And these are neurotransmitters that are located deep in the brain and sort of fan out across the brain. But the point-to-point communication is really a GABA glutamate story. So part of what was, and we didn't have any medicines that sort of, and so in some ways this was a different way of approaching the brain, and through just observation and basic science understanding, coming around to a treatment now that targets glutamate. And then for GABA, there's other things kind of on the horizon in that regard. In fact, after the initial observations of ketamine lifting depression, there's been a lot of investment in, well, what other ways can medicines be developed that affect glutamate signaling in some way? And that's still an ongoing story. Same with GABA. And there's been some other things. Our own work. We took note of findings from basic science that a specific type of potassium channel called KCNQ channel, by targeting that and increasing the signaling there, might work for depression. So we've been working on that. We've had some funding from NIH, and we're continuing to work on that. That would be a unique mechanism that doesn't seem to be directly related to, again, serotonin or the other things. And there's a few another development that's been happening that's, I think, exciting, is starting to move from a treatment for depression as like a broad entity to it's very heterogeneous, right? Some people have more or less negative mood. Others have, which I didn't mention much before, is just they're not really sad, but they really don't respond to pleasure. Like they don't enjoy anything. That's called anhedonia. Very closely related to negative mood, but it actually does seem to be distinct. It seems to have a distinct signature in the brain and cause, and some medicines. So that could be a specific target. Well, maybe a medicine works for anhedonia. Maybe a different type of medicine works for just that feeling of very low and sad, or other aspects of depression. Certainly things like anxiety and what we would call dysphoria go along with that. So starting to try to parse. So I've seen this now, both in the academic literature, in the academic space, we've approached it this way, but even in industry, starting to try to match medicines for specific, maybe it's the cognitive aspect of a disorder, right? We've seen this. So that's really a new direction in the last 5 to 10 years, and we'll see if that bears fruit, but there's some exciting developments in that direction.
How about areas of diagnosis and subtypes of depression? Yeah,
very, very. I mean, these are sort of, in my mind, two sides of the same coin, right? If I want to subtype the depression so I know how to match which treatment to give the person, right? I would say right now the clinician still doesn't have a lot to go on in terms of you have depression of this type. Even the classic, the DSM gives us melancholic, subtype atypical. These are things based on symptom presentations and history. I think most studies have shown that those subtypes, they don't really hold up over time, in the sense that people, they could present one point and they're atypical, and then later melancholic. Some early studies suggested that one type responded better to one class of antidepressants than another, but none of that has really held up that well. So I would say we're still searching for subtypes. There's been some exciting and even very recent publications using tools like brain imaging to do functional brain imaging, looking at brain networks and trying to then group to say, okay, I imaged 100 or 1,000 people with depression, and then sort of you could split them into 3 or 4 groups and say this group had a certain brain signature that, let's just say, was dominated by reduced functioning of the prefrontal cortex, and another one by overactivity in a different region. I'm oversimplifying, but that would be the sort of we see the term sometimes biotypes. So I would say it's exciting, but still early days. It's kind of where we're trying to get to as the clinician. I want to give my patient a brain scan that's going to help me know which of my sort of ever-growing toolbox, right, of different types of antidepressants, and well, who needs a medicine versus psychotherapy, right? Wouldn't it be nice to do a brain scan or a blood test, but the blood test might be just too far away from what's causing the depression, right? Which is really, it's a brain, right? These are functional brain conditions. These are brain disorders. So we probably need to look at brain, and I think we're just in the early days of defining subtypes that eventually clinicians can use to basically towards personalized medicine, right? I'm not just going to give you the first antidepressant that's on my list from the APA, but I'm going to give you something because your brain scan said you're going to benefit. We're not there yet, but that's the goal.
I see. Well, thank you very much, Dr. Murrough, for your background on depression and the details of treatment and diagnosis. It's very informative, and glad to have you.